Welcome, Michael Rachlis.
Thank you, Jane.
You have deep concerns about the way we manage chronic disease care. What's the problem we have? Where do the problems lie?
I think we need to appreciate where they came from, which is that we initially covered hospital care, then physician's care. We have a patchwork quilt coverage for home care, and we have not really had much in the way of focus on primary health care, the key part of our ambulatory health care system in this country. So as a result, our outcomes for acute care are pretty good compared with the rest of the world, but our outcomes from chronic disease are not so good. According to studies done by the Commonwealth Fund in the last couple of years, comparing Canada to several other countries, Canadian family physicians are the least likely to have electronic health records, the least likely to work in teams, and Canadian diabetic patients appear to get the least appropriate follow-up care. So we've got some serious problems managing chronic disease, and as a result, although there haven't been formal studies done, literally thousands of Canadians with diabetes and asthma, high blood pressure, and other conditions are dying prematurely every year from deaths that could have been averted if they had had better management of their chronic disease.
And you mentioned that chronic diseases are particularly poorly managed.
Our acute care system, as near as we can tell, compares with the best of the world. If you have a heart attack in Canada or a serious car accident, you're pretty much as likely to survive as anywhere else in the world. But on the other hand, our management of chronic disease actually seems to be worse than in most other countries, where diabetics and other people with chronic disease are less likely to get the care that they need to keep them healthy.
What does it mean for patients when their chronic diseases are poorly managed?
A study 6 years ago of patients with asthma in Canada and their doctors showed that about 60% of Canadians with asthma did not have their disease properly controlled. They were at risk of developing an emergency, being hospitalized, or even worse, about 500 Canadians die every year from asthma, and all of those deaths should be preventable. One of the most ominous signs of the survey was that neither Canadian patients nor their doctors seemed to appreciate how bad was the asthmatic control. Canadian patients said that 90% of the time they were under good control, even though when challenged on specific symptoms, 60% of the time they weren't in good control. And Canadian doctors thought 90% of the time they were able to get good control of their asthmatic patients. So, and I think that that's the situation with many chronic diseases, where neither patients nor their treating physicians really appreciate that they're not getting the right care, and this is leading to lots of suffering and hospitals being full of patients who shouldn't have gotten sick to begin with.
What changes should we consider in healthcare delivery that would improve chronic disease management?
We now appreciate that the follow-up for people who have chronic disease has to be much more multifaceted and comprehensive than we thought in the past. In the old days, we might have thought, well, you just go to your doctor every 3 months and he takes your blood pressure or measures your blood sugar or something. But now we appreciate that, in fact, on the physician side, you need to have a comprehensive team involved in patient management, because, in fact, people with chronic diseases tend to have a number of people looking after them. They just aren't necessarily working together in a well-functioning team. And most of the follow-up for patients with chronic diseases like diabetes or high blood pressure, arthritis, or asthma, most of the follow-up, routine follow-up, should actually not be done by physicians, but rather nurses probably are the better person to do the follow-up. And if there are problems or special concerns, physicians, of course, family physicians and specialists might need to be brought in, but so might physiotherapists and dietitians and social workers and others. So that we need to have a really well-integrated primary health care team doing the patient follow-up. And then on the other side, we also appreciate that patients have to really be in charge of their own conditions. They live with their conditions. If they get a complication, they might die from it, and they need to be given the tools to really take responsibility. And that means a lot more patient self-management. Patients need to be taught not only about their medications and their side effects and what they need to do if they start to get sick in terms of adjusting their medications, but they need to not only know but have the opportunity to improve their health. That means that they have to have access to how to eat right. They need to have access to exercise programs. If they don't have the income to join a health club, that health regions or health authorities need to figure out ways, particularly for low-income people, to be able to get into the exercise programs that they need. So we're not doing a good job on the healthcare delivery side, because typically we only have family doctors, maybe working with a non-professionally trained receptionist, trying to do all the things that a team needs to do. And then on the other side, patients are not given the tools to be active co-producers of their own health, if you will.
So there's a range of support they need and a range of sources it should come from. Where should we begin?
I think that there are lots of ways that we can start. One of them is that for chronic patients who are leaving hospital, particularly if they're over 65, we know that they're very likely to be readmitted to hospital. Across the country, roughly 20% to 25% of patients with heart failure, which is the most common reason why people are admitted to hospital these days if they aren't having a baby, then we know about a fifth or a quarter of these patients are readmitted to hospital within a month. And yet group health in Sault Ste. Marie and the Vancouver Coastal Health Region has had great success with comprehensive home care management of these patients, which can reduce the rate of readmission by 50%. University of Alberta study concluded that for every congestive heart failure patient given home care, you saved approximately $2,500. It didn't cost money, it actually saved $2,500 because they were less likely to come back to hospital. And then that's the low-lying fruit, if you will. There's a lot of money to be found there. Actually, you can fund some other programs. And where the next two things I would do would be patient self-management, that we have to get patients better involved. They're the captains of their care. They suffer when their care is inadequate. And we need to launch a series of patient self-management programs across the country. And then finally, I guess the other place I would go is electronic health records. And while we're still waiting for the health system to develop the comprehensive electronic health record that we've been waiting for so long, there are actually opportunities for patients to do this for themselves. The McMaster Stone Church Family Medicine Center developed an electronic health record called Oscar, and you can actually create your own electronic health record. You can maintain it yourself, and when you go to a doctor or a clinic, and if they don't have an electronic health record, as long as they have access to the internet, they can chart on your record.
Really patient self-management then. Thank you very much, Michael.
Thank you.